For those of you who may be joining us, my name's Ed Hickey, and I'm the president of AAKP. Our next discussion topic will focus on building and retaining the expert workforce required for the future of patient-centered kidney care. This is another critical issue facing the kidney community and one that is of shared interest with our allied partners at the Renal Physicians Association. Today, I'm pleased to have AAKP's good friend, Rob Blaser, Director of Public Policy at RPA. We always appreciate Rob joining us to share his insights and expertise, so much of what we gave him in his own panel. Rob, can you speak to us about why this is an issue and what we need to do to keep it on our radar?
Absolutely happy to do that, Ed. And first, I just want to say thank you to the AAKP for the invitation. Thank you, Ed. Like Dr. Cooper, I feel like I've known Paul Conway for 25 years. I think that's true. Known you for almost as long. Love the AAKP staff. Diana Kleins, Jerome Bailey, do great work. Thank you so much for everything you do. So, like all of medicine, nephrology right now is experiencing workforce shortages, and disproportionately so. And this is a global thing, too, for what it's worth. It's not just in the U.S., but, I'm going to talk about the U.S., of course. And there are reasons for this. There's a pipeline issue. There's something called the match in academic medicine, where medical students match up with a specialty that they want to go into. And nephrology's kind of had suboptimal results from the match for years now. And there's a lot of different reasons for this. There's the whole complexity of nephrology. It really is among the most intellectually challenging of subspecialties. A joke I always tell is that I attend a lot of meetings with a lot of other specialty societies, and I'm in a lot of those kind of forums, and I'll always make the joke, well, we all know nephrologists are the smartest doctors in the hospital. And it's funny the response you get from other specialties sometimes, because they no, it's really true. My renal rotation was so hard. But my point of saying that is that it is intellectually challenging, and evidently among medical students that's been reported as one of the reasons they didn't go into it. There's compensation issues. I'm going to talk about that throughout this talk, but organized medicine as a whole, the reimbursement's gone down somewhere between, say, 25 and 29% adjusted for inflation since the year 2000. So, of course, that's no way to build a workforce or to maintain a solid workforce. So that's been a problem. There are lifestyle concerns. Nephrologists tend to work long hours, and another joke I make sometimes, and that I can't take credit for it, I heard it somewhere else, was that being a nephrologist is great training to be a hospitalist. And that's unfortunately a joke, but there is something to that, actually. And the whole deal with hospitalists is they have much more predictable work-life balance. They tend to work like an 8-hour day type thing and can go home, and that's not the case for nephrologists. And then there's also, in the context of lifestyle concerns, there's also the issues of work-life balance. Physician burnout is a real thing. Among occupations, physicians either at the very top or the top of occupations in terms of suicide rates. So that's something that's got to be accounted for. So, to the extent, I don't want to sound like an old boomer here saying these young kids don't want to work as hard. God bless them for taking care of themselves and being healthy and seeking that work-life balance, but it is something that does affect the workforce, of course. Moving on to midlife and established nephrologists, again, it's the same kind of issues. The compensation is being reduced relative to everything else. There's, of course, the broader administrative headaches of running a nephrology practice if you're doing that. Prior authorization, having to be on the phone with insurance companies all day to get things paid for. That's a horrible situation. So there's a lot of administrative headaches. There's the graying of the nephrology workforce. There are a lot of nephrologists that are retiring right now, and so of course that affects the raw numbers as well. There were the ongoing reverberations from the pandemic. There were a lot of older nephrologists who just decided to retire then, and of course that has a difficult difficult impact as well. Regarding what can be done, I want everyone to know RPA did a panel on this about a month ago at a meeting we had, so a lot of my thoughts are from some of our panelists there, people that run like the biggest nephrology practices in the country. And they've offered bonuses and done increased salary market adjustments for new doctors. But this, of course, comes at a cost to, the other doctors in the practice. And there's, again, with the reimbursement, there's quite often no offsetting revenues for these kind of things. So we probably need to have more fundamental fixes. Things like, again, revamped Medicare reimbursement that has an inflationary adjuster like the Medicare Economic Index. Again, I'll just say this right now, nephrology for 2025, not nephrology, all of medicine, but of course nephrology included, is slated for a 2.8% payment cut for 2025. The expectation is that that might happen. Congress is going to intervene, but they'll probably give half of it back. So medicine's going to get about a 1.5% pay cut. If they tracked it to something called the Medicare Economic Index, which accounts for inflation, then I think medicine would get something like 3.6% pay raise for 2025. So you can see the delta between what the Medicare Economics is saying, plus 3.6 or whatever the number is, 3.5, and minus 2.8. So got to do something about that. Got to have something that reflects inflation. You could get administrative relief in the forms of policies that pull back on things like prior authorization. There's been legislation out there the last couple of years about the use of unused J-1 visas. I don't understand the visa program that well, but evidently there's a bunch of unused visas, and if they go unused, they expire. And the idea is that you could take those visas and give them to health professionals in the country foreign-born health professionals, and they could stay longer. But, the whole immigration issue is so highly charged right now that that bill's not going anywhere. And I actually brought it up on our Hill Day in late September, and the staffer I met was like, don't even go there, man. So, that's probably not happening. And then, of course, medical student loan relief, serving in rural areas or something like that, the medical school debt that people experience is huge. I'm going to transition into talking about the advanced practitioner level. Pretty much everything I just said about physicians applies to nurse practitioners, physician assistants, and clinical nurse specialists. They're all reimbursed by Medicare as well, so they're having those pay cuts. And then they're also having their own pipeline issues. Nursing school enrollment is not growing fast enough to meet demand. There's a faculty shortage. The average age of a nurse is 52, and they're all retiring right now. So I think there's an effort like, how do we make nephrology as a specialty, and this applies across all staff types, how do we make it more attractive? It is a pretty special thing. Professionals need to talk a little bit more positively about their jobs, the job security, the opportunities, the respect. Also, particularly from the advanced practitioner perspective, addressing the environment, start acknowledging the challenges, develop a culture of well-being, a sense of belonging, and a little more input into governance of the practice. A lot of times I think the advanced practitioners believe that their opinions aren't sufficiently accounted for in how the practice is run. So that's another thing to do as well. And then you can do monetary perks in terms of work-life integration, workplace safety, and again, getting rid of administrative burdens that are unnecessary. I'm not the best person to talk about this, but I know the dialysis facility staff are also going through this. It's kind of funny that towards the end of the pandemic, I talked to a great RPA doc. I won't say where he's from, certainly won't mention his name, but I was like, we brought up the CMS quality reports, and he was like, as if I'm filing the quality reports, we can barely get people dialyzed right now and it was because of the staff. But that's the thought that, they don't even have the staff to do what the government supposedly is requiring them to do. So that gives you an idea of what the impact of workforce problems can have in the dialysis facility. This also applies at the nephrology practice as well, keeping good administrative staff, good clinical staff, good non-clinical staff in the nephrology practice is really hard as well. And they try to do things like what we just talked about with the nursing staff, of like giving them more input, more ownership of what goes on in the practice, those sort of things, of course, monetary benefits and other perks. But it's a challenge as well because that it's at all levels of the nephrology practice, from the physician down to the administrative staff. So, Ed, I think I'll stop there.
Okay. I have a quick question. So I'm on the nephrology board on the American Board of Internal Medicine, and I wonder, in medical school, nephrology is basically a week over the course of the 3-year programs that they have. Is there any utility in expanding that so that they're exposed to more, that would increase the number of people who get interested in the profession?
I would think there would be. I don't want to get out over my skis
Right,
because
no,
there are people that do that for a living, and I'm a Medicare fee schedule
not-
guy, so this is kind of a busman's holiday for me anyway. But I would think there would be.
Okay.
I think one of the things that happens in medical schools, and we talked about this with regard to the nursing, but the loss of mentors. Evidently, if you talk to the older nephrologists, they'll all say, "Oh God, I had Belding Scribner telling me what to do," or Chris Blagg, or plug in your name, Haim Sheridan here, and that was a great thing. Not that doesn't happen now, but you see that mentioned among the reasons why the workforce isn't doing better is there's been a loss of mentors.
Right.
So.
Got it. Well, thank you.
Sure.
And thank you for coming here today
Yep.
and sharing your thoughts, and appreciate it.
Happy to be here.
Always great to work with you.
Always great. We treasure the relationship with AAKP,
We do,
so
and
thank you
us
for
as
being
well.
here. You all are too.